Hello everyone, good morning. I hope that you all are doing fine. And we will start with our today's pages of TG. And I would also try to do one Odell case today for sure. And sorry for sometimes, because I'm working as well, so sometimes I really find it hard to record and post the video. But whenever I'll get the chance, I will try to complete TG and I will complete the Odell cases and some important articles that are really, really important for the exam purpose. All right, so without wasting time, we will start with this topic today. So, we have completed the renal toxicity and cardiovascular toxicity, what drugs we can prescribe for those patients. So, now we are in this topic in which if the patient has gastrointestinal toxicity. So, in which patient there is a risk of this gastrointestinal toxicity? First of all, if the patient is old. Second, if he has already a history of upper gastric bleeding or peptic ulcer disease. Then Helicobacter pylori infection, or if he is using additional drugs that increases the risk of upper GIT bleeding or perforations. For example, which drugs can increase the risk of bleeding? Those are the anticoagulants, antiplatelets, SSRIs and SNRIs. These drugs mainly for antidepressants, so and the systemic corticosteroids. So these are the drugs that can increase the chances of bleeding from the GIT. So you should be careful if you are prescribing NSAID in these patients. And if the patient is comorbid, like he has significant comorbidity or he is smoking, like the smoking can reduce our immune system response and it can lead to so many infection. And just basically smoking um just stops our immune system to work against any antigen or any bad thing. If a decision is taken to use NSAID in a patient at increased risk of gastrointestinal toxicity, for suitable choice, we will look here. So from here, so if the patient has these risk factors, okay, so you took the history and there are these risk factors. So what you can do in those patients? Always avoid non-selective NSAID. That means you cannot give them ibuprofen, diclofenac, and naproxen. Which drug you can give them is the COX-2 selective, which is the celecoxib. If a COX-2 selective NSAID cannot be used, then use only paracetamol for mild to moderate pain. And if there is severe pain, then use paracetamol plus oxycodone. Okay, so this is a bit simple. So in kidney patient, you are not prescribing them any NSAID. You are just consulting with their GP. Okay. For the cardiovascular toxicity, you can prescribe them ibuprofen or celecoxib, but for limit the treatment for only 5 days. Okay, but I would say always first go for paracetamol and always be in more safe side, or try to ask from their GP like what management you can do with them. And in the patient with the GIT toxicity risk, you cannot prescribe the non-selective one, so only NSAID that you can prescribe is the celecoxib. Otherwise, if the patient has only mild to moderate pain, then give the paracetamol, and if he has the severe pain, then give paracetamol plus oxycodone. And in patient who have had the NSAID induced bronchospasm, like we will start from here. Okay, so if the patient who has the risk of bronchospasm, like asthma or any respiratory problem, then avoid non-selective, means do not prescribe them ibuprofen, diclofenac, and naproxen. You can only give them COX-2 selective, which means celecoxib. So for the both of them, like the GIT toxicity patient and the bronchospasm patient, you can prescribe them only celecoxib. And otherwise, paracetamol for mild to moderate pain, and for severe pain, paracetamol plus oxycodone. Okay, then if the patient is elderly patient, okay, so assess the need for NSAID in elderly patient particularly carefully, because these people are generally at increased risk of kidney, heart, and GIT adverse effects. Because with the age, as we studied here as well, so with the age the risk increases. So if the patient is old age, so he has more risk of getting renal toxicity, cardiovascular toxicity, and gastrointestinal toxicity, so you need to be more careful with them. Elderly people are also more likely to have comorbidities and take other, and with the age, we are not that healthy, okay, as we get older, and sometimes we do the old people are taking multiple drugs, so we need to make sure that these NSAIDs would not interact with them and would not cause any harm to the patient. If a decision is taken to use an NSAID in an elderly patient, then you need to see for suitable choice. NSAID with a short half-life are preferred. So which are the short half-life? Those are the this one, ibuprofen, because short half-life means you need to give them 3 to 4 times a day. Whether the celecoxib has the longer half-life, so we only need to give them 1 to 2 doses per day. Okay, then women who are pregnant and breastfeeding. So, if possible, avoid NSAIDs throughout the pregnancy. So, there is a scenario in exam for, especially for part one, in which the patient is pregnant, or I think she's pregnant or breastfeeding, something like that. And they ask you, like, which is the preferred drug to give to the pregnant patient. Okay, so that is always the best drug is the paracetamol only, because they said avoid NSAIDs throughout the pregnancy. That would be the best solution. But if the safety of NSAID use during the first 8 weeks of pregnancy is uncertain, so do not prescribe any NSAIDs in first 8 weeks, like in the first trimester. NSAIDs should not be used beyond 32 weeks of gestation, because they can be associated with adverse maternal and fetal outcome. There are fewer data on the use of COX-2 selective NSAIDs than non-selective NSAIDs in pregnancy. So, if a decision is taken to use an NSAID in a pregnant woman up to 32 weeks gestation, a non-selective NSAID is preferred. So, first of all, the best solution is avoid all the NSAID and only prescribe paracetamol. Okay, but if the patient, if there is certain condition where paracetamol is not really helpful and you need to prescribe the NSAID, then the ibuprofen would be the better one, because with the COX-2 selective, which are the celecoxib, there is not good data available. Small amounts of NSAIDs are excreted into breast milk as well. However, these amounts are unlikely to cause harm, and breastfed infants, ibuprofen and breastfeed, like if the women, she's like breastfeeding, so there is chance that some amount of this drug can go inside the infant through the milk, but the harm would not be much. Ibuprofen is the preferred NSAID for women who are breastfeeding. Advise breastfeeding mothers to feed their baby just before taking their medication. Okay, so for example, so patient needs to take the medication at 8 a.m. Okay, so you advise them that feed their baby before 8 a.m. so that there would be minimum amount of drug in the breast milk. Choosing an analgesic regime for patients at increased risk of NSAID related toxicity. So this topic we have already covered with those with the upper topics. Like we read about the renal toxicity, you are not doing anything. With the cardiovascular, you can prescribe but minimum for 5 days, and for the GIT only celecoxib, and for the bronchospasm also only celecoxib. So the practical advice to minimize harms when prescribing. So every time you would be prescribing any NSAIDs to the patient, you should be telling him these 4 points, which are: take the NSAID regularly rather than as required, using the lowest effective dose. This we always, we more commonly seen, like the, even I have also seen with my parents, they only take the drug whenever they feel like, oh, I'm having fever or I am having headache. No, these drugs should be taken as course. They should be taken regularly. That's how they work. And use the NSAID for the shortest duration possible and not more than 5 days. The risk of adverse effect may increase after 5 days of use. So take the drug regularly for 5 days. Combine the NSAIDs with the paracetamol, and as soon as stop the NSAID and then use paracetamol alone. So this is the modified pain strategy. So if the patient is in pain, so advise him to take both the drugs together. But whenever he starts to feel bit well, then ask him to stop using NSAID and use only the paracetamol, because we all know that the paracetamol is the most safest drug. Seek review if the NSAID is still required after 5 days to avoid inadvertent long-term use. So if the patient is still in pain after 5 days, ask him to come back to you, like come back for review, like what is actually happening. It is no longer advised that NSAIDs be taken with food. Previously, we used to ask the patient, like, take it with the food, but now they said that do not advise it to take it with the food to reduce adverse effects, because there is no evidence to support this approach. Additionally, if the patient takes the NSAIDs with the food, it delays its peak concentration and it also reduces the rate of absorption and can result in less effective pain relief. So, in brief, you should not advise patient to take it with the food, because food impairs with its absorption. Then paracetamol used in dentistry. Paracetamol has analgesic and antipyretic action. So it does not have anti-inflammatory action. That's why it is not very helpful in the pain relief. But we can use this drug because this is the most safest drug, and a low incidence of adverse effects compared to other analgesic drugs. However, in overdose, it can lead to severe hepatotoxicity. If the patient take, although it is very safe drug, but if still patient take it overly, like overdose, we read in first chapter, like the overdose and underdose both are not good, right? So if there is any overdose, it can affect the liver and cause severe hepatotoxicity. Although generally less effective than NSAIDs, these are less effective than NSAIDs because dental pain is mainly inflammatory in action, and NSAIDs works as anti-inflammatory drugs. So that is the most effective, right? But they do, as we read in previous pages, that they do have certain contraindication in which patient we cannot really prescribe them. So in those cases, the paracetamol is the drug of choice due to its favorable safety profile. Paracetamol is used in combination with other analgesics for the treatment of acute dental pain, because this can result in enhanced pain management or synergistic analgesia. As a component of multimodal analgesia, paracetamol reduces the requirements for opioids. So if the patient has, like, moderate pain, you can prescribe him ibuprofen plus paracetamol. So it would reduce the chances of prescribing opiates. Paracetamol is available in multiple formulations, like in immediate release and modified release, and in combination with other drugs as well. Therefore, patients should be advised to consider the paracetamol content of all their medications to avoid inadvertent ingestion of a higher than recommended dose. So, for example, it is also present in combination with other drugs, right? And multiple formulation is available. So you should ask the patient, like here it is written, the supratherapeutic doses that the patient should not take 4 gram in 24 hours. So the dose would be added and it should not be supratherapeutic because it can lead to severe hepatotoxicity. In adults with severe significant liver disease or who are underweight, cathetic, or frail, reduced doses are often inappropriately used. Sorry. So, so if the patient already has any liver disease, or if he's underweight or cathetic or frail patient, we generally prescribe lesser doses of paracetamol, and that is inappropriate. This may result in inadequate analgesia and consequently use of more harmful analgesics. So if we, because we know, right? So paracetamol does affect on liver. So if we know like our patient has any significant liver disease, we try to prescribe him lesser amount of paracetamol. So, but the patient has pain, so he would take any other analgesia. So that is more harmful than the paracetamol. So, if they state that the therapeutic doses are not at all toxic in these patients group, even the patient has significant liver disease, if he would only take the therapeutic dose, it would not be harmful. But there is an increased risk of liver damage if the supratherapeutic doses are inadvertently taken. The supratherapeutic dose is 4 gram in 24 hours. In obese children, the dose of paracetamol should be calculated using the ideal body weight rather than the actual body weight. So, because in obese children, if we would count according to the actual body weight, it would be the supratherapeutic dose, right? So, in obese, we would use the ideal body weight. When prescribing paracetamol, the dose should be stated in grams or milligrams rather than the number of tablets or volume of liquid, unless the exact formulation to be administered has been specified. Then opioids used in dentistry in combination with non-opioid analgesia and non-pharmacological measures, that is the dental treatment, which is the most effective treatment for the dental pain, and opioid may be used for acute severe nociceptive dental pain in adults. So according to exam point of view, we very rarely we prescribe the opiates. I have not seen any scenario where we are prescribing opiates to the patient, because this is for like pain associated with major trauma or any severe post-operative pain. So we generally prescribe these medications to those patients. Opiates should not be used for pain that is chronic, neuropathic, or nociplastic, or pain in children. So you should not be prescribing any opiates to the children. And if the pain is chronic, and like for example more than 3 months, and it is neuropathic, we will read about these what are neuropathic pain and nociplastic pain in the further pain chapter, except by specialists. Safe prescribing of opiates in dentistry requires the practitioner to be. If you are prescribing opiates to the patient, you should be familiar with the indication, like where it is indicated to prescribe opiate. You should be familiar with the suitability, if the patient is suitable for this patient or not. Because if the patient is elder, he is frail patient, or he is opioid tolerant patient, then it can affect him. Then always weigh the potential of benefits and harm before prescribing any drug to the patient. Be familiar with the opiates suitable for use in dentistry and the formulation, because in dentistry we commonly only prescribe the oxycodone dose Okay, so you should be familiar with that dose as well, because previously we were prescribing codeine, but now they stated that there is no need to prescribe codeine to the patient. Then know how to manage potential if there is any adverse reaction or any drug interaction occur. You should be able to manage it. Prescribe the lowest dose for the lowest duration, shortest duration possible. So for the NSAIDs and paracetamol, we generally prescribe them for the 5 days, but for the opiates, it is only 3 days. Because long-term opioid use often starts with the use of opiates to treat acute pain. Consider the legislation about prescription and prescribing of drugs of dependence. Then what are the harms of the opiates? Generally, when given in equi-analgesic doses, opiates have a similar spectrum and incidence of adverse effects. However, there can be significant interpatient variability as well. And if the patient is elder or frail patient, it may be, but they are particularly sensitive to these drugs. Then, what are the harms associated with opiates are adverse effects. Serious adverse effects means, example, opiate induced ventilator impairment or accidental death as well, are more likely to occur when opiates are used in high doses or concomitantly with other sedative drugs. So, if it is taken, so if the patient is already taking benzodiazepine or alcohol or cannabis, if that patient would take the opiate, then it would be really dangerous for him. List adverse effects that can occur with short-term opioid use. For a more detailed discussion of the adverse effects of opioids, see the analgesic topics in ETG. Aberrant behavior, like sometimes the patient can, get addictive to this drug. So the risk of opioid abuse is high. In some studies, opioid abuse was reported in more than 20% of patients taking long-term opioid use for chronic non-cancer pain. Then there is a risk of overdose for because increased over opioid prescribing rates have been associated with increased risk number in the of fatalities involving opiates and neuroadaptive and physiological changes. Sometimes his body gets dependent on opiate and that dose of opiate stop acting on his body, so sometimes that can also occur. Okay. And adverse effects can be limited by using the lowest dose for the shortest duration possible. And always provide verbal and written education. So, whenever you will be prescribing opiate to your patient, you should be telling him these 3 points, which is do not drive or operate machinery, how to recognize the signs of if there is any excessive sedation. How would you know, like you are feeling very sleepy and it is very hard for you to rouse, so that is a sign. And then to seek medical attention if they become excessively sedated, because these are sedative drugs, right? So right amount of sedation is okay, but if you are yeah, if in some patient, like for example, if they are elder, if they are frail, or in some more sensitive patient, if they become excessively sedated, because this can be an early indicator of ventilatory impairment or experience other concerning adverse effect, then you need to take medical attention. Okay, so these are the adverse effects that are caused by opioids. So, the simple formula to learn this effect is that it would also affect every organ, like for example, respiratory, neurological, cardiovascular, skin, then GIT, and urinary. And just make sure that opioids just reduces everything. It just suppresses everything. For example, in respiratory, it would cause ventilatory impairment, like it would cause excessive sedation with a decrease in respiratory rate. Without a decrease in respiratory rate, Okay, it can lead to accidental death, increased risk of sleep disordered breathing, cough suppression. So, for the respiratory, it can lower down the ventilatory effect, and it can also lead to cough suppression. So, for the neurological, it would cause delirium, sedation. So, it just calms your body in general sense. It just slows down everything. And even the cardiovascular, it would cause bradycardia, vasodilation, hypotension, and in the skin it can cause pruritus or a widespread urticaria. And GIT, it would lead to nausea, vomiting, constipation, then spasm of sphincter of Oddi, and urinary, it would lead to urinary retention and sometimes difficulty with micturition, increased external sphincter tone, and decreased detrusor muscle tone. So just try to remember that it would suppress every system, like for the respiratory, be it neurological, cardiovascular, dermatological, GIT, or urinary. Okay. And then constipation is a frequent adverse effects of opiates. Advise patients to obtain a stimulant if the patient is experiencing constipation. Then you can advise your patient to take the stimulant laxative, which is the Docusat with Senna, if it becomes an issue. Then choice of opiates which you can prescribe in dentistry is the immediate release opiates commonly used for acute pain management in dentistry. It includes oxycodone, tramadol, and tapentadol. Tramadol and tapentadol are sometimes referred to as atypical opiates because they have multiple mechanism of action other than mu opiate receptor agonism. Despite clinical significant experience with its use, codeine is no longer recommended now. So now we are only prescribing the immediate release opiates. Those are oxycodone, tramadol, and tapentadol. So out of these three, tramadol and tapentadol are atypical because they do work through different mechanism, and the preferred opiate is only the oxycodone. So here they have given the summary of all these drugs. Like for example, oxycodone, it is a preferred opiate for the dentistry because we have widespread experience with its use. It has fewer drug interaction and it is more predictable. Okay, then tramadol, it is an alternative in patient who cannot take oxycodone, but it has wide range of adverse effects and drug interaction. Tapentadol is also an alternative if the patient cannot take oxycodone, but it is more potent oxycodone than tramadol. It is more potent opiate than tramadol, and it also has several drug reactions and adverse effects, and its immediate release oral formulation is not available on the PBS. So PBS is, as we read in first chapter in prescription, so PBS medication and the non-PBS medication. So there is no role in pain management, that is codeine. There is no good evidence that the codeine is any more effective than paracetamol or NSAID or improve analgesia when combined with paracetamol or NSAID. Codeine containing preparations have been abused because it is used as abusive drug. Codeine is a prodrug that is metabolized to morphine. There is significant interpatient variability as well, but there is increased risk of toxicity in certain group. Those patients are patients who are ultra rapid metabolizers, breastfeeding mothers, children younger than 12 years, children 12 to 18 years who have recently had a tonsillectomy or adenoidectomy for obstructive sleep apnea. So, in brief, we do not really prescribe codeine to any patient at all, and not even tramadol or tapentadol. We are only prescribing oxycodone, and that is also very rare because these do have, a suppressive effect. And whenever you need to prescribe this drug, prescribe it only for not more than 3 days. All right, so we have covered today's pages, and I'll see you guys in the next video. Thank you so much for watching my videos. Yeah.